Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more. Today we're joined by Kahlen Darr, a genetic counselor here at the Mayo Clinic who specializes in inherited retinal and complex genetic disorders. We're diving into how genetic testing works in ophthalmology and what clinicians need to know. Tune in.
Today, I'm excited to introduce Kahlen Darr, who is the lead genetic counselor in the Department of Clinical Genomics at Mayo Clinic, Rochester. He is board certified and has developed subspecialty expertise in hereditary hearing and vision disorders, with extensive expertise in multidisciplinary clinics, including the Inherited Retinal Disease Clinic, Bardet-Biedl Syndrome Clinic, NF2 Clinic, and General Genetics Clinics. His work spans both genetic counseling-led care models and collaborative practice alongside medical geneticists. Kahlen is involved in education and workforce development, mentoring genetic counseling trainees through the University of Minnesota Mayo Clinic training program. He also serves as a site coordinator for the Undiagnosed Diseases Network at Mayo Clinic, helping evaluate patients with complex and unresolved conditions. His clinical and academic interests focus on expanding access to genetic testing, integrating genomics into everyday clinical care, and improving how both patients and providers understand genetic results, especially in ophthalmology. Welcome, Kahlen.
Thank you, Brittany. It's been great to be here.
It's wonderful to have you.
Yeah. All right, so let's jump in and talk a little bit about what it's like to be a genetic counselor. What does the encounter look like? What is it like to be in that room with you and the patient?
I try to come across from a very open point of view with my patients, so a lot of it is very patient driven. So there's always the things that we're going to hit from time to time, but it's really important to kind of meet the patients where they're at. But the general flow of it is we work with the patients to kind of contract to understand what their goals are for the genetic testing in the process. We do a lot of education, as you know. We kind of go over the genetic testing and what it can do, what it can't do, and all those different things. And then just kind of make sure that they know that we're the person there to help them through the whole process more than anything else.
For me as a pediatric ophthalmologist, there's a host of times where I wonder or I know I need help in this realm. I know, Brittany, with your inherited retinal disease practice and the advances you've created here as a leader to help to form these partnerships with our genetics teams, and we all benefit from these. A lot of people are not in positions that are as complemented that way. But when I send a patient, then I write down there, I need a genetics consult. This is a bilateral cataract, and likely there's a genetic component, and I sign that order. What's the typical schedule look like? What's the typical, in terms of getting there and a visit, and when, just lay out kind of what would be the expectations of the first encounter they had with you, leading up to blood tests or things that are following. Yeah. But what would a provider that refers to you expect from the first visit, and what should they tell their patient in advance of it?
That's a great question. So some of it depends a little bit about who you're seeing, because obviously I'm a genetic counselor and there's a delineation between me and medical geneticists. So I'm not a physician, so I will not be talking about care or management. I will not be placing those orders. I work hand in hand with doctors that will do that. I will help patients understand some of the guidelines sometimes. But when you refer to us, we review the cases. We have a triaging process where we look and we kind of sometimes determine where patients go and who's going to see them. We have some great workflows that Dr. Scruggs and I and Dr. Scamenti have worked through where we can do some of these things that are a little bit more streamlined, which I love. But we will end up seeing the patients and kind of evaluating them and determining what the best next steps are. I would tell your patients to expect just to have a conversation more than anything else, to have a good conversation about genetic testing and really let them know that they are the drivers of this more than anything else, because I think that's the important thing to understand. Genetics is very personal. It's very important to understand that it has downstream effects for the patient and their family. And so we always like to make sure we're coming at it from a point of shared decision making. So I always let the patients know it is their choice whether we move forward or not.
And talk a little bit about getting a family history, like the family tree or pedigree. Do you do that beforehand? How long does that take? How long does, in general, a genetic counseling session take for specifically an ophthalmology disorder?
Yeah, so if I see them as a genetic counselor only, I will do the family history. And it takes somewhere between 15 minutes to half an hour. It really depends on the family and the patient in front of us. Some have very small families, limited information. Those obviously go much quicker, right? And other ones have very large families. I literally just had one where there were 16 aunts and uncles on both sides of the family. That obviously took a little bit longer. But I tend to set the stage with the patients of letting them know, we're going to ask targeted questions about your family. Whatever you know is fine. If you don't know something, that's okay as well. Again, making it a safe space. So I tell patients, I'm really good working in the grays. If you think you're about this age or roughly, that's good enough for us. And then we go through and we talk about person by person, generation by generation, and kind of talk about things that are, chronic, long-term, maybe not diet, health, or exercise related, but really more things that we have a suspicion for, like, for example, with ophthalmology, with the inherited retinal space. So vision problems of course importance, but there's other things that can connect as well, like hearing loss, intellectual disability, kidney problems, all kinds of other things. So we go pretty broad. There also are subspecialties within genetic counseling. So I'm a general genetic counselor. I'm kind of the one, I see a little bit of everything. Love the ophthalmology space. It's my favorite. They're the patients that I really like working with the most. But I also do see things with inherited, clotting disorders, or kids with autism, or sometimes they'll see cancer patients as well. And I'm of the opinion for myself that I'm not going to send you to somebody else to talk about these things. So I use that session to also understand, is there anything else from a genetic perspective that could be important for these patients to know as well? So I kind of try to be a little bit more inclusive.
I know certainly pediatric ophthalmologists appreciate teamwork and family-based connections to unpack these things, because there's some sensitive issues and information, and a lot of even the results are sometimes vague. We're going to get into testing and test results, but it's just phenomenal to have a team like you partnering with us, because right from the beginning you're building these relationships that then you're relying on after. And then, I'm sensitive to certainly providers that work in settings that don't have close relationships like that. Yeah. Can you just comment on how important that bedrock is, and then once results start coming in, why those relationships, and why the voice of a genetic counselor in unpacking what the results might mean, why is that so important?
It's foundational. I mean, you said it, bedrock. Having those pre-test counseling sessions to really help the patients understand that you're there as their support system, it makes those back-end conversations so much easier. One, from a technical point of view, like just having heard some of these complex thoughts before, like we're talking about variants and genetic changes, and sometimes we get more complex with things like repeat disorders and things that get very confusing for people that don't have a science background. But having that ability to meet them where they're at and kind of connect to them and actually kind of speak to their level, that's really big. That pre-test session really allows us to kind of understand what level we can speak to them at, what their goals are, what they understand. And we actually have a privilege that a lot of other providers don't have. I get to spend sometimes up to an hour with my patients, and we know in this day and age that's a rarity. It's and I take that as very much a privilege. So I get to hold space for them and help them kind of understand what's going on. Yeah. So I think it is foundational. I think the bedrock is a good way to put it.
So for our listeners and for all of us who are really busy in clinic, right? Say they're in private practice, they're seeing a patient for one thing, and then they look into the back of the eye. It's completely different, right? It's undiagnosed inherited retinal disease, and genetic testing is clearly something they should discuss. It's not expected, and that discussion has not been allotted into the chair time needed for the cataract eval, right? For that ophthalmologist, 2 questions. One, if they get genetic testing as like a send-off or a saliva swab, and what are they missing out on if they don't incorporate a genetic counselor? That's one question. And 2, for those who want the options of partnering with a genetic counselor but maybe don't have one in-house, what are the options for them?
Yeah, I think the thing that they're missing is that personalized care that we help the patients walk through the whole process. You all are busy. You're seeing a lot of patients every day. You don't have the time to go through all the different options and things like that. You try your best, but sometimes it's not you just don't have the resources or the knowledge to know where the places to go are. Genetic counselors, we spend our careers looking at genetic tests, looking at the options that we have, talking about the different things that we can do. We think about cost to the patient, right? Because there's a vast array of different costs for the patients depending on insurance type, Medicare, Medicaid, private pay, sponsored testing, and we're really good about helping the patients make sure they get the right test. So I think that's part of it. The other part of it is that partnership that you develop. I think one thing Brittany and I do really well is we talk about our results a lot. You know, like I get her amazing front end phenotyping where she tells me exactly what she's looking at, and that helps me on the back end understanding the variants. So for people that don't have as much experience with understanding genetic testing results, it is very symptom driven. It's very important to understand what you're looking at. So having that relationship where I have the expertise on the variant interpretation and you have the expertise in the phenotyping makes it a world of difference. So I think there's a lot of like personalized care that you can get with that, right? And getting that relationship. But of course, we're not everywhere. There's only, I think, like maybe 8,000 or 9,000 of us in the country, something like that. So it's growing. It's a field that's getting bigger, and we're needed in a lot of different places, but you know, it's limited. So there are options. Most genetic testing labs do have in-house genetic counselors. So you can reach out to a company like Invitae, who does a lot of testing, or other ones that we work with a lot. And they will sometimes have that built into their system where the patient can call in, do pre-test and post-test counseling. That's great if you don't have any other options, I think. There's still not that holding the hand through the whole process that sometimes we are able to give. You might not be able to call that exact genetic counselor again. Like you have an option to call a genetic counselor, but it might be somebody that you've never worked with. Whereas with me, I've met them, I can connect with them through portal message, phone calls, in-person visits, and help them through the process when things come up and things change. But those are great ways to do it too. So anytime you can get a connection with a genetic counselor, I think it's a good thing.
One thing that I've learned over the years is not some patients surprise you on what they want. Like obviously we have a sponsored panel where it's free for the patients. The initial testing is free. We get most of the high yield genes specifically for retinal dystrophies, but not everyone wants a sponsored test. And so for the people who are like, well, I always do my retinal tracker or I always do this, if you give them the options, people surprise you. And so it really does take a long discussion of costs and options and what does it mean to have a sponsored program? What is exome versus genome? And so, yeah, I just wanted to put that plug in as, you know, sometimes patients, if you really give them all the options, they will choose something that maybe you wouldn't have chosen for them.
Yeah, and I think the sponsored one is a good point to bring up, Brittany, because some people don't want their information out there. For example, with the My Retina tracker, part of the cost to the patient, because there's always a cost, they're getting something out of it, is they're collecting data. Now, the group that's collecting data is a great group. It's the Foundation Fighting Blindness. I think they're doing great work. I think we likely all agree with that. They're just trying to advance the research on inherited retinal diseases, and they're a good place for researchers to reach out to say, I need some data on this, that, or the other. Some patients find that to be a great thing because they want to be a part of that research. They want to have those opportunities. Other patients are not as comfortable with that, you know. So I always like to have a really strong conversation with them about, is this something that you would like? If not, here are other options. And I generally do have other options, but they involve insurance, which is its own joy, you know. So.
Well, I've certainly appreciated over the years the work that you do together in inherited retinal disease, and Brittany's, your role in helping to lead that from a clinical side and research side is phenomenal. Just for me as a pediatric ophthalmologist, if I see a patient with an inherited retinal disease, and I'm going to say, Brittany, help. But just talk about first line, first steps, genetic testing and counseling for a patient that is new coming in with a suspected retinal disease. Maybe we're leaning in one direction or not, but you know there's something up with the retina and we're going to get help. Can you just
Can I start for a second?
Yeah.
Can I start that?
Yeah.
I think it's really important when someone looks in and says, I think there's a retinal dystrophy, to not jump immediately to genetic testing. And I think we'll get into a little bit to variants and variants of unknown significance and uncertain significance. It is so important to have a really high pretest probability of what you think it is. I love to put my money down. Like, I think it is this gene, or I think it's this, potentially 5 genes. Because when the genetic testing comes back and you have 8 variants, if the variant that you thought was going to be there is there, immediately it's like, okay, I think I'm getting closer to the answer. Versus retinal dystrophy,
Shotgun approach.
get a genetic testing. All of these come back. Now you're like, oh, scratching your head. Well, I don't have the testing to kind of tease out which one is real. So I'm gonna then give it to Colin, because I think the first step is me, right? It's the specialist who can do all of the ancillary testing, do the visual field testing, the autofluorescence, do the potentially microperimetry, the OCT, the ERG, full field ERG, multifocal ERG. Tease out, is it really inherited, right? It could be autoimmune, it could be cancer, it could be toxicity
Great
from
point.
medications. We don't want to miss that and just jump straight to genetics. So once we phenotype the patient and really narrow differential, then Colin comes into play.
Yeah. And I think just exactly what Brittany just said. It's really important for us to have that information on the front end to actually be able to understand what test is the most appropriate. So if they come in and it is isolated, it's a cone rod dystrophy, or there's something that's like, this is all it is, panel might be appropriate, right? But say we have more information that there's more syndromic conditions kind of associated with it, like we're seeing kids that have developmental delay or hearing loss as well as that, it might be more appropriate to go broader and look at a bigger scope of things. So having that phenotype on the front end really helps us do our job better for the first pass, meeting the patient, helping them understand the testing that we can and can't do. But then also when we get the results back, it's huge. You're right. Because if you get all these different variants, it can be really easy to say, oh, well, that could make sense. It's kind of like you're biasing yourself a little bit. So are you looking at the variants and thinking, well, this could fit with what's going on? Or are you looking at what you're seeing ahead of you and making kind of an educated...
You're making the puzzle piece fit.
Exactly. Yeah.
When that's not really the one that goes there. Yeah.
And almost anything that's going to come back on a report is going to connect in some way, shape, or form. Otherwise, we wouldn't order that test, right? So, for example, if we get back an uncertain variant, which I'm sure we'll talk about that in a second, something that's inconclusive, that's just retinal disease. It's really important to understand, well, what is the actual retinal disease and what are we seeing in the patient? Does it actually make sense? Because we get inconclusive or uncertain results on almost every single report we get back. So it's really important to have that front end work as well. Yeah.
Certainly, there are plenty of inconclusive comments and details. In the current diagnostic landscape that you work through, what is the yield for genetic testing for an inherited retinal disease and or ophthalmology broadly? Like, what is the hit rate that allows you to take away something that's tangible that you can communicate?
Yeah,
This is our direction.
patients want to know this. They
do.
ask us every time.
Yeah, and actually in the inherited retinal space, it's one of the highest that we have in genetic testing. As a whole, when we do genetic testing, we find an answer about 30% of the time. That's across all specialties. That's cancer, developmental delay, hearing, vision loss. That's an average across the board. In the inherited retinal disease space, it's between 50 and 70%, depending on what papers you read. So it's actually pretty high, And a lot of that is also driven by that pre-test probability. So if you have a high suspicion, you're on the higher end. If you do more generalized testing, you're probably on that lower end, right? And I think even the 50 to 30% that we're not picking up, there's a lot of times that there's probably a genetic factor that we're just not understanding as well. So in the IRD space, it's pretty high. In the ophthalmology space in general, I actually looked this up beforehand because I was curious. It seems like it's a little bit more predicated on what you're seeing. So for, you mentioned cataracts earlier, for congenital cataracts, it's pretty high, right? Because we're expecting there to be something, I think it was like between 75 and 80%. For other things like microphthalmia and things like that, it's actually much lower, which surprised me a little bit when I actually read that. So it's a little bit of it depends, but it's an area that's really exciting because we do tend to find an answer a lot. Makes it harder, more work for me on the back end when we get the positive results, but it's nice to find answers for people because they get really excited.
All right, so let's talk about the negative results.
Yes.
So patients come in, they're like, I've had genetic testing. Often it's a panel, and they say it's negative. And what I have learned over time is negative doesn't actually mean negative. It's inconclusive, and that doesn't mean it's not inherited. And so how do you explain that to patients? How do you set them up for that? And if they have an inconclusive panel, how often do you then expand it to broad-based sequencing?
You'll hear this a lot from genetic counselors, is it depends, right? So it depends on the situation. But to answer the first part of your question, we do a lot of, for myself, I am very transparent with my patients on the front end about what we can find and what we do. So I'll start off by just explaining what genes, chromosomes, proteins, all that stuff is at a level that they can understand. I've counseled molecular geneticists to people with intellectual disabilities, so you got to make sure that you're kind of connecting them where they're at. And if you do that pre-test counseling well, it helps them understand that we're doing the testing, we're sequencing their DNA, we're looking at the base pairs, those A's, T's, G's, and C's, and then we're comparing it to just a reference sequence. That reference sequence isn't perfect. Like, it's a composite of a bunch of different people that we put together over the years to say, what's different from this? Everybody has differences. And so this is what I tell my patients, you're gonna have differences. And so the lab then has to go through and say, what evidence do we have that these are the answer? Well, sometimes we just don't know. We don't have enough information to say that this is the answer or not, or maybe we don't know what this actual area of the gene or the chromosome does, or we just don't know that this particular gene has a relationship to the eye. So while we know a lot of things, we don't know everything. So most of the time when I talk to my patients with a negative test result, I tell them we don't say it's not genetic, it's like a double negative there, but we tell them we just haven't found anything yet at this time. If we go to a broader test, that's a conversation that we have about what is the yield, what's the possibility of we're going to find an answer. The first line panels are really good in the inherited retinal disease space. They find an answer a good chunk of the time. We have some back-end data that we're working on publishing. It's been a long time, but that is showing it's about a 5 to 10% yield when we go to the bigger tests, and that sometimes, again, depends. There's histrionics there. If it's a panel that's been around, was done 10, 15 years ago, you're probably more likely to pick something up if you do updated testing, right? So short answer is we would want to look at it and tell the patient, touch base with us every couple of years. Come back and see, we're going to come back and see Dr. Scruggs for clinical care. We can reevaluate if we're going to do additional testing at that point, and then just keep touching base over and over again, even if we do the biggest test.
Can I add to my question? Sorry, Eric.
No, it's all good.
All right. So say someone has broad-based sequencing, say genome sequencing. It is inconclusive, some variants that we don't really think is the answer. Several years later, so obviously they don't need new testing. They've already had genome sequencing, but it can be reevaluated. How do you explain to them that maybe a few years later there might be new genes that we didn't know were related, and science has caught up to the point where now we can find new answers? And how often do you do that process?
Almost every time I do a genome, I talk to patients about that. So the rule of thumb is we touch base in 2 to 3 years to consider a reanalysis. That's just kind of standard of care for genomes across the board. The idea is that we're learning what a couple hundred genes do every year, right? I think that's slowing down a little bit, but I think that's a good rule of thumb is we're learning what new genes do all the time. There's 20,000 genes in the human body. Last estimate I saw, we know what 30 to 40% of them do, right? So if we're learning more and more, then it's important to kind of keep looking and keep going, and keeping this research going is important. So it's a lot of what you said, Brittany. You know, science is learning. We're figuring out new things all the time. We're making connections. Technology is improving, you know. So we're at the point where we're coming up on some new technology coming out in genetic testing, long read sequencing, where we're looking at the genome in bigger chunks. So that's helpful in a lot of different ways, and could be important to reevaluate the genetic code in a different way, right? But yes, for a general rule of thumb, we have the genetic data. We don't have to run it again. The labs tend to offer that at least once for free. But then after that, there is some insurance implications. So that's why we like the 2 to 3 year spot, because it's a good area to kind of sit in.
So before that report is processed by you in a very caring and supportive teamwork way, it often gets uploaded into Epic or other spaces. And so my first comment is, nowadays patients often have their results, say MRI, before I've seen them. And sometimes they call in a panic for reasons that are justified or not justified. And so just comment on how often, is it the same true with genetic testing? And then number 2, when physicians that are not closely related in the genetic care team, what do you advise them to do? As an ophthalmologist getting this report, like what areas of the report, how do they look at it in valuing? So 2 questions. One is, how do you prep patients to not get too excited over things of uncertain significance? And then number 2, how would you advise physicians that are not genetic counselors or providers read these reports? Great questions.
Every patient I talk to, I have that conversation with, because yes, they do get the reports sometimes before I do, because they'll get uploaded to the portal. They're actually able to pull them up right away. Sometimes it takes like couple hours to get filtered to me, and then we
Yeah.
review them. And of course, I can't always just look at the report and know if it's the answer or not, right? And so I always counsel my patients. I tell them, look at the report, read it, do research if you want to. I'm never going to tell a patient not to, because I would, and I don't want to be a hypocrite, right? But I do also tell them that these reports are dense. They are hard for a layman to understand sometimes. They're really just a bunch of letters and numbers if you don't know what you're looking at. And they're very easy to misinterpret. I've had people misinterpret them. We've had experiences in the past, right? And so I tell patients, basically, Dr. Google is the most terrifying place on the planet, right? So if you see something, you're going down that path, it's giving you anxiety, let me be your person. So that way we're at least looking at the same things together. From a physician's point of view, I would make sure that you're very comfortable understanding what it's saying. So big things like, what are the actual classifications that it's showing you? So we've bandied about the term variant of uncertain significance a couple of times. Mm-hmm. So maybe I should explain what that is. So when we do the genetic testing, we are looking for those genetic variants from that baseline. We're finding evidence to say, is this the answer or not? These are things like, has it been seen in control populations or has it been seen in healthy populations? Is it conserved across species? Is it in a hotspot of the gene? All this different stuff that we're doing. And the American College of Medical Genetics has basically set up a tier system to say what things should qualify as a pathogenic, benign, or uncertain variant. It is changing. They're coming up with new guidelines in the next year or two, so there'll be a little bit of differences. But basically, there's like 5 categories: benign, likely benign, uncertain, likely pathogenic, and pathogenic. So likely pathogenic, the rule is that 90%, we have a 90% confidence that it is symptom causing. Pathogenic is it's 99%. An uncertain variant is right in the middle. Right, we have something that it could fit, it could make sense with what's going on, but there's not enough evidence to put it over the top. So from a provider's point of view, I think it's important to understand that not all uncertain variants are going to be suspicious. So what I would say is, for one, look at the classification. If it's uncertain, you're going to have to do a little bit more research. You're going to have to look into it to say, how well would this fit if it does make sense for what's going on. Other things that we do as genetic counselors that we're really good at is we look at the interpretation that the lab gives us. Because it's an art as much as it's a science, right? So you're relying on people to do the interpretations of the evidence that's there. And genetic counselors will look at the evidence that they give. And I've argued with labs before. We've had constructive conversations and said, I don't know if this piece of evidence is really supportive. I actually think this makes more sense. Or maybe they don't have the patient's information that we have in front of them, because we give them as much as we can, but we can't give them everything. And so they don't understand, well, this person actually has this feature that would make more sense, and this is really suspicious. We've done that multiple times, right?
For sure, yep.
And so understanding the language that they use and the interpretation is an important part to look at. And also something as simple as inheritance patterns. We have to make sure that if you're looking at a recessive condition, is it a heterozygous change, only one change, or is it homozygous and they have 2 changes? Along with that also is, if you have 2 changes, are they in cis or in trans? Meaning, are they on the same copy of the gene or are they on the opposite copies of the gene? And that can be very important, because we find genetic changes where somebody carries 2 changes on the same copy. That's not the answer, but it might look like it from the report. So that follow-up is really important to kind of go through. So I think those are the big parts. Does it fit? Is the inheritance, does it make sense? What is the interpretation, and what evidence are they using?
So we are getting into the space of clinical trials and gene therapy. We're advancing science, really exciting times right now. Oftentimes, patients have to have a likely pathogenic or pathogenic variant or variants in order to enroll. So say they have a variant of uncertain significance. I know that we've done this together.
Yeah.
How do you elevate status?
Yeah.
What are all of the things that go into that, and working with the company to make sure that now the world, if that variant ever comes up again, is classified differently?
Yeah. Again, it depends, right? So sometimes we have to look at the evidence that they're giving us and see where are we falling in that, right? So something as simple as doing parental testing can really be very powerful, right? Because one of the things we talked about was setting phase. That's is it in the same copy of the gene or opposite copies of the gene? Sometimes the only way to know that is if you test the parents, because if mom carries one, dad carries the other, then you know they're on opposite copies. If it fits with the phenotype, that could be enough to elevate it. You could do family variant testing of multiple people that are affected. So there's an algorithm they use. I don't know the exact numbers, but if you have a recessive condition, you need so many people affected that also carry these genetic changes, dominant so many, but that's called segregation. We can help elevate these variants if we see it enough in the family history. Functional work. This is an area that's sometimes hard to find, but say It's a gene that's expressed in RNA, and it could be important to understand how it's functioning at that level. So, for example, splice site variants, it can be important to know what is the RNA product from the gene, right? And so functional data can be really helpful as well. It's kind of the gold standard. It's hard to get because it's not anything that's clinically available. You can't just go down to Walmart and get a murine model and start making mices and things like that. But it's a bunch of different things, and some of it depends a little bit on what the gene actually is. Some of it might be as simple as doing biochemical testing to look for analytes in the blood. So, yeah.
I want to switch gears. You're a genetic counselor, and many of the last minutes have been really about the genetics part of it. I'd like to talk about the counseling part of it.
Yeah, my favorite part.
We always have moments in life that are with news that are hard to share. You have the difficult challenge of sharing genetic results, sometimes that are very disappointing news to families and patients. Share with us your approach as a counselor. How do you go into the room? How do you approach that unpacking of a result on paper, knowing the whole picture you've developed and the foundation of a relationship?
Yeah.
What's your approach to that situation?
It's evolved. I can tell you that right now. Because when you graduate, you're a new genetic counselor, you're fresh. It's the most terrifying thing in the world, right? To give somebody life-changing results. You go in over-prepared. You have all these slideshows and visual aids. And as I've kind of gone further, I've realized I don't want to make suppositions on what the patients are going to want to know and want to hear. So I take it more as I'm there to hold space. So one thing that one of my supervisors, when I went to the University of Minnesota for my program, and one of my supervisors, he's a wonderful supervisor that sees people in the neurology space, which you can imagine is a very hard space to be in. And he taught me, you're not there to fix. You're there to just help and be there and hold space. So I think I go in with the thoughts of, I want to meet them where they're at more than anything else. So just kind of holding the space, allowing them to feel, which is hard for us sometimes, right? Because we're fixers. We wouldn't be in healthcare if we weren't fixers. But sometimes you can't fix, right? And I think it's really important to understand that this is one of the hardest moments the patient is going to have in their lives, and you just need to be there to meet them where they're at. And it sounds kind of crazy, but it's probably one of the most fulfilling parts of my job. It is one of the hardest parts of my job. I'll say that right now. Sometimes I go home wrecked, and it's hard. But I know, with my experience and my privilege of having the time to spend with the patients, I can give those results to people in a way that is safe and caring and just present. And I think that's huge. So I take a lot of joy. That sounds a little bit weird to say, but a lot of satisfaction is probably better to help them understand what's really going on, to make sure they have the right information to really understand what life's going to look like, and just being there for them. It's huge. It is.
Yeah. Sometimes as an ophthalmologist, we see patients and the eyes are failing, the vision's getting worse, and it's just the first symptom of many to come. And the eyes are, the family thinks that potentially this child is just visually impaired, but the answer comes back that it's something so much more.
Yeah.
And oftentimes we're the first ones to diagnose a neurodegenerative disease. My question is regarding genetic counseling versus getting the involvement of a geneticist. And can you walk us through, when is that appropriate? When should people partner with the team approach and having a full body workup and additional testing in these really hard situations?
I think give yourself some grace. You guys are amazing with the eyes. You guys know it forwards, backwards. It's one of the most complex areas of the human body. Allow that person, the medical geneticist that has the expertise in multi-system care, to be your partner, right? So we work with Dr. Lisa Scamenti. We have this great honor to have, I love our setup that we have. Brittany's great with the eyes, and she has background experience with genetics as well. I know genetics and genetic testing. Dr. Scamenti is obviously a medical geneticist, but she also has experience with hearing and vision loss. But I think it's important when you have these multi-system things going on to have somebody who can look at the whole picture more, right? Because you guys have your focus, you have your specialty, and that's what you're going to pay attention to. The geneticists are really good at kind of looking at the bigger picture and making sure things happen. I think about them in some ways, they're almost like a quarterback, right? So for these complex genetic conditions where you have hearing loss, vision loss, kidney problems, they can make sure that those things happen in the right way, right? Because things can get lost. Some of these patients, they see like 7, 8 different specialties, and that's hard to kind of keep track of. And it's nice to have a geneticist to kind of sit there and go, oh, well, I haven't seen you haven't had an echocardiogram in a couple of years, or we haven't checked your kidney levels, or, I'm not a doctor, so I don't know the things that can happen. But having that person to be able to be a partner with you and kind of help you through that process, I think is huge. I would imagine you guys are busy, so you don't have time to do all the multi-system care. I know you guys try to, and you're amazing at what you do, but I'd say use them when there's like more things than just the one system, just the eyes.
And for people who are doing their own genetic testing, potentially there's going to be a surprise.
Yep.
That's going to be very, very hard to share with the family. Just a reminder to all of us, including myself, it's important that when you have those experiences, to partner immediately. Like, don't wait on the genetic testing and calling. You have to, I would give a plug to bring them in, have social work develop it, the counselor, the geneticist, give space for the child to play, right? Leave the room if needed.
Child life services.
Right.
Great, yeah.
But those are some of the hardest moments I've had as a clinician.
Yeah, I've definitely had moments where I left crying. We have some cases where you have these beautiful young children coming in and just a little bit of vision loss, and you end up telling them something very hard, like a life-limiting condition. I think it is a good point, Brittany, that ophthalmology can be one of the first places that see these kids, and just be prepared if you're going to order genetic testing that you might find some very serious implications that come back, and be prepared for that.
Do you share with families when they're getting these panels that there are genes on there that could lead to a diagnosis that could be fatal?
I tend to leave it a little bit more vague. I don't want to overly worry parents, because most of the time that's not what it is. It depends a little bit. If there is a strong suspicion, like there's MRIs that are showing something different, or I try to kind of set the stage a little bit more. I try to leave it as genetics can actually affect multiple areas of the body. So I want you to be prepared that we might find something that is completely unrelated to what we're looking for, but it has health implications. And patients are usually like, oh yeah, well that's the point. But it's hard to really conceptualize that these things can be more severe than that. So it's a balance. It's tough. I don't want to tell every patient that comes through that there could be a life-limiting condition, but I also want them to understand that there could be things that are unexpected that can be severe. So.
Well, and in that, it even goes beyond the complexity of what you're assuming the scope is for the child, but the scope is for the whole family. Whether other siblings or other relatives. Yeah. Just thoughts on how you approach those implications or those discussions in a delicate way. You're almost doing a team counseling, but realizing there's individuals in the room or individuals that are not present.
Yep.
Advice on that, or thoughts on that journey with families?
Yeah, part of that is the pre-test counseling, right? So what I like to do is that really strong contracting when we're first talking to the patients, understanding what is their goal. Because some people is like, well, we know this is what's going on with this child, but we have this child that's 3 years younger. I want to know the risk there, right? And so understanding that is their goal on the front end can be helpful for that, right? We call that cascade testing. It is probably one of the hardest parts of my job, honestly, besides the difficult news, because I have some cases. I'm thinking about our one family with the OMD that we end up testing like 25 people in this family for this condition, and it's a lot of work. It's a lot of things that can happen. Sometimes one result can turn into dozens of appointments for multiple different people. So it's definitely something that comes a part of it. Another benefit of having a genetic counselor is I can help you guys do that as well. So,
can you talk a little bit about the family letter that you write and how you get the word out to families in this situation? Yeah,
so for most cases, I write a family letter, which is a detailed letter that has things like what lab the testing was done at, some identifiers, so that way if somebody does want to do genetic testing, they know where to go and how to reference it, the specific genetic variant, briefly about what the condition is. I usually don't make it too in-depth. I try to keep it to one page because you get too much information, patients don't pay as much attention. And then on there, we also have information about how to find like a genetic counselor or how to get referred back here to Mayo. Our national society is called the National Society of Genetic Counselors. There's a great resource on there called Find a Genetic Counselor. You can actually plug in, and as providers, you guys could do this too. If like you don't have access to a genetic counselor, maybe you want to build some relationships, you can see, are there genetic counselors in your area that are willing to see patients? So it could be a way you could see them on there, reach out to them. But I put that in there for the patients because, we're here at Mayo, we see people all over the world, all over the country. I don't have licensure in every state, so I can't order testing for everybody, right? So I give them that letter so that they can take it to a local provider, and then they can get the testing from there and meet a genetic counselor like me in their own state. And I think it's really important to have that, because patients are always like, how do I explain this? Like, what do I do with this? Because it's complex. There's a lot of stuff. So having something they can take home, I think, is really important.
Are there any mistakes you see ophthalmologists make as they communicate or send patients in the genetic realm, either over-testing, under-testing, communication? What advice do you have for ophthalmologists listening that would be just encouragement or to try to improve process?
Yeah, that's a really delicate balance with the over-testing versus under-testing. We want to be good stewards of medical dollars, right? We want to make sure that we're paying attention to what's important for the patient. I think part of that, what Brittany was saying earlier about having a good pre-test probability of knowing I am suspicious of this is important, because these tests can cost thousands of dollars if they're not covered by insurance. And, if you're working with a parent who has a kid that has something going on, they're like, I'm going to do everything I can. Well, in my mind, I know there's like a 1% to 2% chance this is going to find something, and it's more likely it's not. And no matter how I explain that to them, they still are going to want to do everything. So I think from your point of view, understanding when it is appropriate to refer to genetics is huge if you're going to do that. Unfortunately, we have seen times where people have misinterpreted reports or they haven't communicated them in the right way. So I think that is really important, because now with the new legislation where people have access to all their medical records, they see the reports, they get these, and the labs actually will send them to them because legally they have to if they request them. So we've had situations where something happened and the report didn't get disclosed to the patient. They took it, they made their own assumptions, and then things happen from there, right? The human mind is very powerful. You can get things like functional blindness. I know you know what I'm talking about, right? So I think it's important that if you're going to order the test, you take ownership of everything that can come from it as well, and make sure that you have the plan to moving forward on how to disclose that information and have the time to do it.
Yeah. And for the listeners, we've had some cases where the patient received the report and without counseling read the report and found one variant and needed two, but only had one on the report, but they made the assumption that they had that disease. Years later, they were functionally blind. So the mind is powerful, very powerful. So that segues into risks and benefits. So the bullet points that you go through with patients when you're counseling them, what are the benefits? I mean, clearly we want a diagnosis, but what are all of the other benefits and also the risks? A lot of people are like, well, what are the risks of genetic testing? Clearly there are some.
Yeah. For the patients, I always contract with them first to understand what their goals are, but I can almost tell you it's almost always one of three goals. Are we going to do anything to change things? In the eye space, people are always thinking about, can I have my vision restored? I tend to talk to the patients more about preservation rather than restoration. I think it's important to have hope. I think you're great at that, Brittany, hearing them talk about hope and the things that we can do to actively change things, but also the practicality of what could happen to make sure you're also great at making sure they get the resources that they need, And so I'm always kind of talking about, is there anything that we're going to do to change things? That's one big goal. That's my gold standard. If we can do anything to improve quality of life and care and, anything that's going to make things better for the patient, that is the happiest moment for me. Other health concerns, those are the big things that I want to make sure, because if there's a genetic condition and it has relationship to heart disease or kidney function or something like that, we want to make sure we're paying attention to it. So if there's something else we should be looking at that we're not. Risk to other family members is a big one for families too. Like we mentioned before, like, are other people in the family going to be affected? If I have more children, is there a risk for them? What can we do to mitigate that risk or understand that risk? And then the third one for the patients is always just the psychological knowledge, just knowing what it is and having that diagnostic odyssey end, because some of these things take years. We were just talking about the patient who was 20 years. They were looking for an answer for 20 years, and we were able to find it. And they were the happiest I've ever seen them, right? Because now they have an answer. They know what's going on. That big family we talked about before is like, 5 generations? I think it was something like that.
I think I know 17 of them.
Yeah, it's just crazy. And they were just really happy to finally have answers, right? From the risk point of view, I think there's always the risk of overcalling on certain variants. I think can be really detrimental sometimes because we can over-medicalize these patients. So we have this uncertain variant, maybe it could fit, maybe it couldn't, but it turns into now we're thinking about doing MRIs on kids that we have to sedate them, or doing, multiple different specialty visits, which can get very expensive. We got to think about cost in this day and age, right? We could find out things about family relations that we're not really expecting, right? So we can find out that parents aren't parents, or parents are more related than we thought they were. That can come out of genetic testing. So there are some downstream consequences that can happen. There's also the psychological portion of sometimes people think they want to know and then they don't. So I think it's really important to really take that time to go through, do they really want to know this information? Are they really thinking about the implications that can happen from there? So I think those are kind of the big risks in my mind.
For families who are still family planning, do you bring up in vitro fertilization?
I can sometimes, yeah. So if they're at that point, we talk about things like pre-implantation genetic testing, where basically you go through IVF and then you test the embryos for the genetic condition. We've talked about prenatal testing. Sometimes people just want to be able to do like amniocentesis or CVS to know if the child's going to be at risk or not. And then we also talk about things like, if it's something that you don't want to pass on, there's other ways of having families. We talk about that as well. But also, again, always, it is their choice. Sure. We're always going to tell them, you are the driver of this more than anything else, and whatever information you want. Yep. That's the important part.
It's phenomenal to be able to tap your brain. It's always humbling how fast it goes in our time. I guess my question would be just you've given us a wonderful display of what a multidisciplinary genetic practice looks like, incorporated in a care team that buys in and really supplies this team approach to patients. Where's the field going in 5 to 10 years? There's changes with genetic therapy expanding. What's your vision of the future for teams like this?
Yeah, I think there's a couple of ways to answer that. One, there's so much research going on right now. There's so many clinical trials. Gene therapies are been around for a while, but they're getting ramped up, it seems like, a little bit more. You know more about that than I do. But having the ability to actually have intervention for these patients is huge. For the longest time in genetics, there wasn't anything we would change, right? This is not something we could cure. We're getting to the point where we can change genes, we can insert things, we can do these different things. So I think it's really important to have this on the forefront, especially in the retinal space, because there's a lot of areas that are happening there. From a care model perspective, unfortunately, there is a lack of genetics professionals in the country. There's genetic counselors, we can be trained somewhat quicker because it's a 2-year program for us, but there's only about 50 schools in the country that do it. It's very competitive, it's hard to get into. There's less geneticists than we would like to have as well. So I can see it moving more towards the embedded model like we have with you in ophthalmology, where I'm down there working hand in hand with a professional, and I understand that, but still having that geneticist we can reach out to with a complex case, because I'm good at what I do, but I'm not perfect. They have a lot of specialized knowledge that I'm not going to have. So having that kind of backup to kind of go back to is still really, really important. But I can see it turning into more of this multidisciplinary care where like a genetic counselor is embedded more in these different areas like ophthalmology, rheumatology, immunology, neurology. And we do a lot of that here at Mayo. We actually have that already.
Yeah.
Yeah.
Well, I just want to close by saying thank you. Thank you for your expertise. Thank you for your partnership, honestly. And it's just great to talk about this with genetic testing. It's not just a diagnosis, it's giving prognosis, it's giving hope, it's giving a treatment plan, and options that they didn't think were possible sometimes. So the way that you approach it is beautiful, and I appreciate having you here.
Oh, thank you, Brittany. I appreciate working with you as well, and Dr. Bothan as well. It's nice to actually meet you in person. I saw your name a lot, got to see a lot of your patients, but I want to say thank you to the ophthalmology team for having such buy-in with it. I think your department, I always enjoy working with you guys, and you're always such good partners to work with, and you really engender what it is to be colleagues, and I love it. It's great.
Thank you.
Thanks for being here.
Yeah.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.